Hello again. My name is George Minowata, and I'm the volunteer pulmonologist for the MAVEN Project. Thank you all for attending and being part of the MAVEN Project. I especially want to thank our friends at Generations Family Health, who have served the communities of Eastern Connecticut since 1984 for hosting today's session titled When Exercise Intolerance is Not Asthma, presented by Dr. Ben Nelson. Before I hand the mic over to Dr. Nelson, a little background. Dr. Nelson is an assistant professor of pediatrics in the Division of Pediatric Pulmonology at Mass General Hospital for Children. He received his medical degree from Georgetown University in 2005 and completed his pediatric residency in 2008 and pediatric pulmonary fellowship in 2011, both at the Mass General Hospital for Children. He subsequently joined the faculty in the pediatric pulmonary division at Mass General Hospital for children. He became associate program director for the pediatric pulmonary fellowship in 2012 before becoming the program director in 2015. In addition, he's director of the pediatric bronchoscopy program and director of CME in the Department of Pediatrics, where he oversees all CME programs. And with that, Dr. Nelson, the mic is yours.
Great. So thanks so much for the invitation. I'm excited to chat with everyone today. Please feel free to put all the questions and comments and arguments in the chat in the Q&A as we go here. Let me go ahead and those are my twins who are now 13 years of age. Don't talk. I can't believe I have teenagers, but that's for another subject. Okay, so we're going to be talking about when exercise intolerance is not asthma. And let's see, I have no disclosures related to this subject. And I believe this activity is accredited for CME credit for all of you. Okay, so we're going to be talking about the clinical presentation. When we talk about what's not asthma, we have to be on the same page of what is asthma. And specifically, we're going to be talking about exercise-induced vocal cord dysfunction, which is extremely common and I see all the time. We're going to talk about which patients need further diagnostic testing and which do not, which can be treated with empiric therapy. And then choosing appropriate therapy for pediatric patients with exercise intolerance. And when to consider other entities. So let me start just by outlining kind of a case that I see quite routinely. This is a 17-year-old girl, and she was referred to the pediatric pulmonary clinic because she had shortness of breath for about a year. She was a cross-country runner, and she would describe having difficulty getting the air, getting a full breath, and having difficulty both on inspiration and expiration. She would say that her heart would race. She would complain of wheezing. She said that she felt tight. She didn't cough. And she noticed that the symptoms were more pronounced in races versus practices, but she did get out of breath with practice as well. And she says the symptoms occur a few minutes into exercise. So she had a diagnosis of asthma as a younger child, and she outgrew it and really hadn't been treated with bronchodilators or nebulizers or steroids for quite some time. She has a little bit of anxiety, but she's not being treated with any medication. And should be family history here. Mom has a history of exercise-induced bronchoconstriction. So out of curiosity here, if you guys were seeing this patient in your clinic, what would you think? And maybe just type in the chat just to get a sense of where people are. Do you think this history is consistent with exercise-induced bronchoconstriction? Is it anxiety, deconditioning, paradoxical vocal fold motion, maybe something cardiac? Do you need more information to kind of make a diagnosis here? And I'll just give you a sec to put in your answers. Hopefully everyone's had enough coffee. Couple answers are coming in, couple varying answers here, which kind of fits because there are some symptoms of multiple entities here. So why don't we go through and keep going here? So I want to make sure, before we get back to the case here, I want to make sure that we talk about some definitions and terminology. We'll think about a differential diagnosis, and then this will illustrate various phenotypes with 3 different cases. So different definitions of wheeze. The reason why I put this on here is because patients and doctors are going to have different definitions. Patients will tell you that they're wheezing, and they may or may not accurately be describing wheeze. And I've learned that you really need to be specific and almost mimic the sounds for them. Is it on inspiration? Is it on expiration? Is it stridor? Is it wheeze? Is it stuttor? Is it something else? And it can be hard to tease that out sometimes. Just remember that wheeze does not equal asthma, just as absence of wheeze does not rule out asthma either. Exercise-induced asthma, just for definition's sake, I tend to not to use this terminology because I think for the patients it's a little bit confusing. The bottom line, the reason why is exercise doesn't cause asthma. It's patients who have asthma may be triggered by exercise, just like they may be triggered by viral illness, weather change, or an allergic reaction. But exercise can definitely be a trigger in predisposed patients. And what exercise does is it triggers bronchoconstriction in patients with asthma. And so that's why we use the term exercise-induced bronchoconstriction as opposed to exercise-induced asthma. It's a little bit of nuance, but just for definition's sake, that's what I tend to say. Now, one of the key things about exercise-induced bronchoconstriction is the timing. And it's fairly consistent that you really don't see symptoms until about 10 to 15 minutes into exercise. And that's pretty common. And so if patients are describing symptoms within a minute or 2 of exercise or 30 to 40 minutes into exercise, you might want to think of something else that might be going on here. So for this patient, she really didn't have manifestations of asthma. She wasn't coughing. The symptom timing didn't really fit. And of note, she didn't receive any benefit from pre-treatment with bronchodilators. Furthermore, she was only affected with certain activities. She said that races were challenging for her, although she had some symptoms and practices. For the most part, it was really those intense races that were giving her a hard time. Now, since she's telling me that she was not responding to bronchodilators, I always review spacer technique with patients. First and foremost, most people use spacers incorrectly. This was a study back in 2011 that showed that less than 10% of patients actually use a spacer properly. And it's not a pill, it's not a liquid, you don't know that it's all getting in. You really need to watch and see what they're doing because although it's quite intuitive to us, it can be quite challenging for patients. And so asking them to bring in their inhalers and spacers, show you what they're doing can really be beneficial because if they're not using a spacer or if they're not using the spacer correctly, they really aren't getting enough of the medication into the lower airways to tell whether or not it's being effective. So first and foremost, everyone needs to use a spacer no matter what age you are. And without the use of a spacer, I really can't say that we've had failure of treatment. Remember the goals of exercise are going to be different for every patient, but what I think about when I'm have patients who come in with dyspnea and exertion is that I want everyone to be able to fully participate. And one of the things I always try to do is remove any unnecessary restrictions. I never want patients to have to sit out of activities, whether it's from asthma or something else, if not necessary. So although a lot of times the patient will have exercise-induced bronchoconstriction and asthma, there are always other things to think about, and we're going to go through these. And remember, the presence of one doesn't necessarily rule out other entities. Oftentimes, multiple etiologies can be causing the patient problems. So kind of going through here, if you start thinking about airway, this is when we think about vocal cord dysfunction. And although we know a lot about it, you know that we don't know everything about it when there's 3 different names in the literature associated with the same disease entity. So you'll see exercise-induced vocal cord dysfunction, you'll see paradoxical vocal fold motion, PVFM, you'll see exercise-induced laryngeal obstruction, EILO. And the bottom line here is that it's a central airway obstruction where if you look in figure B here on the right, what you're looking down the glottis opening and anterior and posterior aspects of the airway. And in vocal cord dysfunction, a signal will go to the vocal cords telling the vocal cords to inappropriately adduct or close. And so it's kind of like breathing through a smaller straw. And I'll show you an endoscopic view in a little bit. And we'll review that in much more detail as well. Although I'm not a cardiologist, I always kind of think in the back of my mind, the heart and the cardiac system can be involved in exercise, and you want to make sure there are no red flags and that you're not missing something. So here, the way I think about it is that symptoms reflect an inability to adequately increase your cardiac output. So you get exercise intolerance and easily fatigued. You want to think about hypertrophic cardiomyopathy. I always ask about family history. I always ask patients about syncope. I figure they would probably tell me if they passed out during exercise, but you'd be surprised. So I always have asked about syncope and near syncope and any family history. Their patients can have arrhythmias. They can have long QT syndrome. Again, family history and medication use might be interesting things to note on your exam. But honestly, most of the time in an otherwise healthy child, it's probably not going to be a cardiac issue that's causing their dyspnea with exertion. Patients can have congenital heart disease, so that's important to note. And patients can develop either have primary or secondary pulmonary hypertension, which can be manifested as exercise intolerance as well. So these are some of the things I always ask about on kind of a review of systems. We talked about syncope. I ask about palpitations, dizziness. Now, the presence of these does not mean there is a cardiac issue at play here, but it's just part of the puzzle. And then on physical exam, you might hear a murmur. You look for perfusion and cap refill and the like. But again, it's most of the time not a cardiac issue in kids. Restrictive disease, this mainly is pectus excavatum. Scoliosis, if it's severe enough, can cause restrictive lung disease. Muscle weakness and myopathies can do it as well. But probably the most common that you're going to see is a pectus. And here is a CT scan where you can see this is the anterior portion of the chest and the posterior portion here. And you can see the pectus is pressing on the heart. And what that does is it prevents the heart from fully filling up and basically decreases your cardiac output, which then can manifest as shortness of breath with exercise. For a pectus, if you're worried that a pectus might be leading to exercise intolerance, you usually need to do specific testing. Pulmonary function testing, even with plasmography, looking at lung volumes and diffusion capacities, probably aren't going to tell you enough. You probably need to do a formal cardiopulmonary exercise study, which can help determine your cardiac function during exercise. And the reason why that might be important to do, not only in order to make the diagnosis, But in order to proceed with a surgical correction, if that's what the family wants to do, oftentimes you need to show that it's not just cosmetic in nature. And so the ways you do that would be, one, an exercise study showing a decreased cardiac output, or a severe Haller index, which is basically a CT scan, which measures the indentation here of the pectus. So I get lots of referrals for potential dyspnea and exertion due to a pectus. And it's almost impossible to tell on physical exam. I can't rule it in or rule it out based on severity of the pectus, just on clinical presentation. You really do need to do that specific exercise study. So always remember that unfortunately, a lot of patients have anxiety. It's more common now, especially post-pandemic, and that can lead to hyperventilation. And sometimes it's quite obvious that anxiety is playing a role, but sometimes it's not. So taking a detailed history and teasing that out can be important. And then remember that just normal deconditioning is so prevalent in our patient population, and we see that all the time. And remember that exercise leads to increased ventilation. And this increase in respiratory drive may be interpreted as pathologic by subjects who find it limits their ability to perform to their expectations. And I underline their expectations because everyone's a little bit different. And so not everyone is going to be the fastest in the class or able to keep up with their peers. And that may or may not mean that there's a cardiorespiratory pathologic issue. It just might be deconditioning, which can also be teased out on exercise studies. Okay, so let's review some of these cases, and I wanted to kind of focus on what I see the most in clinic. So the first one is an 18-year-old girl who's about to start college, and she was referred. These are all real patients who were referred to me. She says that her symptoms started while she went to a college orientation during the summer, and she describes it as hard to get the air in. It pretty much occurs all the time. So it's not only with exercise, it's worse with exercise, but it happens at rest as well. And when I'm seeing her in the office, her physical exam is completely normal. She does have a questionable history of some mild anxiety, but not being treated with any medications and no formal diagnosis. So she had already tried albuterol by the time she came to me, and that really didn't give her any benefit. She had a chest x-ray and EKG and PFTs as well. So the chest x-ray and EKG were by her primary care physician, and then I did pulmonary function testing in the office. And so on the left hand here is pre-bronchodilator, and on the right hand side is post-bronchodilator. And of note, I did the post using ipratropium or Atrovent, not albuterol. So if you look here at the flow volume curves, above the x-axis is expiration, and below the x-axis is inspiration. And the green is pre-ipratropium, and the red is post-ipratropium. So if you look at the FEV1 to FVC ratio, pre-bronchodilator is 82%, so she's not obstructed. And her FEV1 and FVC percent predicteds were in the normal range. However, if you look at the expiratory loop, looks pretty good, but if you look at this green inspiratory loop, it's kind of flat, which could be just that she didn't take a big breath in, but it was reproducible and she was giving good effort. So whenever you see a flat curve like that, it might signify an obstruction. And if it's on inspiration, that's usually an extrathoracic obstruction. And so that's a level of the glottis and above. Then I gave ipratropium, and you could see just the benefit here visually on the post-expiratory and inspiratory loops. You no longer see that flattening of that inspiratory loop. And her FEV1 and her FVC both increased by 15% and 8% respectively. So the next patient was a 15-year-old female. She was a cheerleader. That was her form of exercise. And she described being short of breath and audible wheeze. She had tried albuterol. There was no help. And during a routine during a game that she was cheering at, her symptoms were so significant. They happened a few minutes into her routine that the coach called EMS. She was found to have both inspiratory and expiratory wheeze, and she was actually hypoxemic. Her SATs were briefly in the 80s. She has a history of asthma, and it's been well controlled for about 10 years. She's on controller meds. And her workup, so she was taken by the EMS, and she was given albuterol continuously, so continuous albuterol. She was given IV solumedrol and given IV magnesium. She didn't have an oxygen requirement when she got to the hospital. And of note, she was discharged in the morning with a pulm referral. So pretty quick improvement. So when we saw her in the pulmonary clinic, she had a normal exam and her PFTs were normal as well. However, what we did was we exercised her. So we have the ability of putting patients on a treadmill and having them either walk or run, or we also have a stationary exercise bike. But you don't need those things. You can, if you have a hallway or depending on what the temperature is outside, you could take a patient outside or in the hallway, have them run and see what happens that way as well. Not always easy to do, especially if you have a busy clinic, but always a possibility to see if you can try to recreate the symptoms. And I'll tell you that sometimes we can, but a lot of times we cannot recreate the symptoms because it's really hard to kind of recreate that scenario where they're really pushing themselves. But for this patient, when we exercised her, she got this central inspiratory wheeze, and she had abnormal PFTs. And so the green loops again are pre-exercise, and then you can see the expiratory and inspiratory loops are kind of cut off when we exercised her. So what we do is I actually was able to have her seen by my colleagues who are doing clinic at the same time over at our airway clinic, which is just right next door to us, because I don't do laryngoscopy myself. Now, normally laryngoscopy is not needed, and we'll talk about this, but it's a good teaching case here. So at rest, this patient had normal vocal cord motion. But then with exercise, now this isn't her exact scope, but this is the same findings. And let me show you what we're seeing here. This is an endoscopic view. And so we're kind of upside down here. So I'm going to pause it. So this is the epiglottis, and these are the vocal cords right below. So this is anterior at the bottom of the screen, and this is posterior at the top of the screen. And if you see here, as we go, you'll see the vocal cords, and they're wide open right now, and they're kind of going in and out, which is normal. And then you can see right there, all of a sudden they close and they're fluttering almost. And and you can imagine that if a patient is trying to breathe through that opening, how they could become quite short of breath. And you can see how they're really adducting there. And then they open back up, then they adduct again. And this pattern kind of continuously happens. And so it's not permanent by any means. And it doesn't close to the point where I would expect syncope or the patient airway closing on them and them having a medical emergency. But you can imagine them trying to breathe through that smaller straw and why they develop the symptoms that they do, and we'll review those. So then the third patient is a 14-year-old male, is a hockey player, and he was complaining of cough, throat tightness, as well as chest tightness. He said that sometimes the symptoms occurred a few minutes into exercise, but can actually occur 20 minutes into exercise as well, so quite variable. Of course, when I saw him, his exam was normal, as the exam usually is when you're seeing them in the office. And he had a well-documented history of uncontrolled asthma, and it was worse over the last 2 to 3 months. So he was having symptoms both with hockey and at rest. And you can see there's medications there. Sorry, I'm just going to take a sip of water. He was on a low-dose inhaled corticosteroid. He was on montelukast, and he used albuterol as his rescue medication. His workup, so we did an exercise study. So this is a simple exercise study. And so just to orient you, here at baseline, this is his baseline spirometry. And then as he started, after he exercised, you can see that the expiratory loop, becomes quite scooped. And then after administration of albuterol, it reversed. And so this exercise study was consistent with reversible airway obstruction induced by exercise. And then if you look at the inspiratory loop, he's a little flat here at baseline, looks okay here, but you could see as he exercises, the inspiratory loop becomes quite flat as well. And so it looks like he's having both an intrathoracic obstruction based on the expiratory loop, as well as an extrathoracic obstruction based on the inspiratory loop. And so this was consistent. All 3 patients were diagnosed with paradoxical vocal fold motion, which is the same thing as exercise-induced vocal cord dysfunction or exercise-induced laryngeal obstruction. And you can see that all 3 patients had very different clinical phenotypes. And you can have patients who are quite mild to patients who have such severe presentations that EMS is called and they end up in the ER or the hospital. And the definition is that it's episodic, it's inappropriate adduction of your vocal cords during inspiration. And this is key, leading to dyspnea of varying intensity. And it's actually the most common cause of upper airway obstruction during exercise. Prevalence in the literature is reported to occur in about 5 to 15% of patients. I'm not sure if that's accurate. My guess is it might even be higher because a lot of these patients go undiagnosed. But regardless, what I want you to take away is that it's quite common and that you will see it in your practice. It's often misdiagnosed as asthma because of a lack of recognition of this entity, because it's not something that is as prevalent as asthma or has been around as much. And so a lot of people aren't as familiar with the presentation. Now, importantly, some patients can have both. And the hockey player that I was describing had evidence of both exercise-induced bronchoconstriction as well as PVFM. So you want to be able to tease that out to determine, is this just asthma? Is this just an upper airway obstruction? Or is there a sign of both? Median age 14, I've definitely seen patients both younger and older, more prevalent in females, but plenty of males have the issue as well. And I really find that it comes out a lot in competitive athletes, people who are really pushing themselves. It could happen when patients start a new, more competitive sport, when they go from junior high to high school, or when they go from community sports to travel sports where it's more competitive. So I try to tease out, is it a new sport? Is it a new environment? Is it more competitive? What has changed when they start to notice these symptoms? We don't really know why this happens. There isn't great literature and controlled studies looking at this. There are retrospective studies, there are case series, there are things underway. We think it might be mediated via cholinergic pathways, and that gets into some of the treatment that we'll talk about next. But the bottom line is we don't know why this happens. We do know there are varying phenotypes in different presentations, and I'll kind of walk through what to look for and how to differentiate. So this table is what I think about and what I always ask when trying to differentiate these two entities. So first and foremost, if we're just thinking about exercise-induced, and I put asthma, sorry, I should have put bronchoconstriction versus PVFM. So when we're talking about patients who are otherwise asymptomatic, so this isn't someone who's having problems with viral illness and weather changes and allergies. They're just having shortness of breath. And so is it occurring with exercise, or is it occurring at rest, or both? If you're having dyspnea at rest, I can't really say that that's due to exercise-induced bronchoconstriction. But PVFM or VCD can occur both at exercise at rest. Much more common with exercise, but it can definitely happen at rest as well. Next is timing. I always ask patients, how soon into exercise do you start to become symptomatic? And I ask them, I say, is it within a couple minutes, 10 to 15 minutes, longer? What do you notice? And I also ask them, are you symptomatic when you're just jogging? And then you become symptomatic when you start pushing yourself or sprinting. I try to tease that out. Where's the location? So what is causing the pathology here? Is it intrathoracic, like in asthma, or is it extrathoracic, like in vocal cord dysfunction? And the easiest way really to tease that out, if they're having adventitial breath sounds or such as wheeze or stridor, I ask them about that specifically. And the only times I've ever had a patient or their family tell me it's stridor and not wheeze is when they're in the medical field themselves, because no one knows what stridor is. And so, but everyone has heard the term wheeze. And so patients will tell me they wheeze, but it's really stridor. And so I try to tease that out as well. There's a lot of overlap. And again, these symptoms that I'm describing here, these are what you would think of for the classic patient. But a lot of times you're not going to see classic patients. There's a lot of variability. So these are just a guideline, and none of these signs and symptoms can be used to automatically rule something in or automatically rule something out. There's a lot of variation. So classically in asthma, patients will describe chest tightness, whereas in VCD, they'll say the air gets stuck in their throat or they have throat or neck tightness. But again, lots of patients might not be able to localize that. And so invariably, more commonly than not, they'll describe chest tightness. I always ask about cough. With asthma, you're pretty much going to have cough, either during exercise or right afterwards. It's very unusual for exercise-induced bronchoconstriction to not have some kind of cough associated with it, whereas it's very rare that you have cough with VCD. And then, although both entities usually end up with cessation of symptoms upon resolution, resolution of symptoms upon cessation of exercise, but with VCD, sometimes the symptoms can last for minutes to hours later. And then most patients, by the time they've gotten me, have tried a bronchodilator, which is perfectly appropriate to try that empirically. And obviously with exercise-induced bronchoconstriction, they should be responsive to a bronchodilator, assuming they're using a spacer and have proper technique. Whereas with VCD, they're not going to be responsive. And be careful when patients tell you, oh, I think it helps, because there's sometimes a placebo effect. Sometimes they are stopping and taking their bronchodilator, so it's actually stopping exercise, which is helping them. And so you really want to have that classic, yeah, I took the bronchodilator prior to exercise and it prevented the symptoms. So workup, for me, almost always PVFM, vocal cord dysfunction, is a clinical diagnosis based on the history. It can be lack of response to medications as well, but usually the history is classic and you don't need to do anything else. However, there are patients, and we all see them, where it's not so classic and there are signs of PVFM, but signs of other things as well. So if you're worried about some other etiology, whether it be cardiac etiology, you might want to do an EKG. You might have a reason to do a chest X-ray, although usually not, unless you're hearing abnormal breath sounds. With PFTs, you can sometimes see this flattening of the inspiratory loop like you see in column B here, but the absence of that does not rule it out. Because remember, you have to create the exact scenario where you get the signal going to the vocal cords telling them inappropriately close. So it can be helpful doing PFTs, but normal PFTs don't rule out the entity. Now, we talked about putting a scope into the airway to actually look at the vocal cords. This is really hard to do. One, because most people don't do this procedure, and even if you do, one, it's not necessary most of the time. And it's also hard to get someone to exercise, recreate the symptoms, and then put a tube in their nose and look at their vocal cords. So this really is rarely done. Treatment. So first and foremost, I try to reassure patients because this is quite scary and it can be quite nerve-wracking. And I tell them, look, there's nothing going on with your airways. There's nothing going on with your lungs. If we do nothing, ultimately these symptoms will go away. However, they can last months to years. And like we talked about before, the goal for me is always full participation and removing restrictions. And so I am always aggressive in trying to treat these patients in order to allow them to fully participate. So first and foremost, I think about anticholinergics because there is some retrospective data and case report data and anecdotal data from my own experience showing how anticholinergics can be helpful. And so the classic one you would use is ipratropium, and you would give it a couple puffs 10 to 15 minutes prior to exercise. And either it'll work or it won't. The hard part is, I don't know how you guys, how the insurance is in Connecticut, but in Massachusetts, they really don't like covering ipratropium inhalers without a diagnosis of COPD. And so oftentimes I'm using a combivent inhaler, which is a combination of albuterol and ipratropium. And it comes in the Respimat format, which a lot of teenagers like because you don't have to use a spacer with that one. And that one should be, I've had good success getting covered. And so I have patients start with one puff about 10 to 15 minutes prior to exercise. They can titrate up to 2 puffs, and they'll know after a week or two whether or not it's helping. I also talk about inspiratory muscle strength training. So there's a device called a Power Breathe instrument. We can't write scripts for it. They're commercially available. And full disclosure, I have no stock in these devices. They're a handheld device where patients breathe in against resistance. And what it is it's muscle training and weightlifting for your muscles of inspiration. So you can imagine if your muscles of inspiration are trying to get that air in with that upper airway obstruction, you could get short of breath. But if your muscles are stronger, then despite that obstruction, you won't have to work as hard and you won't feel as short of breath. So a lot of patients have some success there too. And then the gold standard is actually speech therapy by someone who is trained in exercise-induced vocal cord dysfunction. And some speech therapists are, and some are not. And what they do is they don't use medications. We have a great group associated with us, and they do more in-depth breathing exercises in order to train the patient with different breathing exercises to slow their breathing and open their upper airway. And then some patients will benefit from psychiatric or psychology involvement. There can be an anxiety component here, but there does not have to be an anxiety component here. So it's something to think about and tease out at times. This is the biggest study that I know of, that I'm aware of, looking at patients, pediatric patients with this entity. It was back in 2011, and it was the group associated with Mass General, and they looked at 60 kids. So again, not a ton of data. And what they were looking at is overall success rates with speech therapy. And they showed that there were treatment failures, but almost everyone had a resolution of symptoms spontaneously within 2 years after diagnosis. Sounds like a long time, but at the same time, it's nice to be able to tell patients that this is not a forever issue. And so speech therapy, though, overall treatment success was about 76%. And so if you have that available to you, great. If not, there are other things that you can do as well, such as the anticholinergics, as well as there's other inspiratory muscle strength training and breathing exercises, more simple breathing exercises that are available that you can go over with patients. And those were the slides that I had. I wanted to leave plenty of time for discussion, questions, comments, arguments, and the like.
Thank you, Dr. Nelson, for a great talk. If you have any questions, please put them into the Q&A. You can raise your hand and unmute you, or put them into the chat. To get things going, Dr. Nelson, a couple of questions. You kind of touched on it towards the end, but with regards to spacers, now there are different delivery devices, dry powder inhalers, the Respimat device delivery mechanism. Can you speak to those in relation to MDI spacers and delivery mechanisms?
Yeah, and this is becoming a huge issue with what insurance will cover as well. So in my experience, most pediatric patients either cannot do the dry powder technique appropriately or don't do it appropriately on a consistent chronic basis, because you have to take a huge breath in and hold your breath for 5 seconds in order to get that powder all the way down into your lower airways. And so it's extremely challenging. I would say anyone under the age of 10, they really can't do it. And even kids who are teenage years struggle with that technique. So I much prefer, if able to get it covered, doing an MDI with a spacer. And you also have to remember that using a spacer, depending on the molecule that are in medicine you're using, you might only be getting 20, 25, maybe at most 50% of the medication into the lower airways. And so without a spacer, you're basically not getting anything. With a spacer, you really still have to have good technique. I oftentimes tell the story of a colleague told me that he said to a family, once, show me how you use your spacer. And they said to him, well, I can't because my dog's not here in clinic with us. And he's thinking, okay, this is odd. But he went with it and he said, let's pretend this chair is the dog. And they took the inhaler, shook it up, put it in the spacer, and then sprayed the chair, quote, on dog. They thought that since the trigger was the dog and he was allergic to dogs, that's what you had to do. Now, that's kind of an absurd example, but you'd be surprised in the things you see when you see patients actually demonstrating the use. And so I much prefer MDIs with spacers. The Respimat, that is perfectly fine to use. The spray comes out much less forcefully than the MDI, so you don't need a spacer with that. You do need to do a breath hold. Although there's no data on using a spacer, for some patients, if they really need that medication, I will use a spacer because I think they get some of the medication in though.
I agree with you with that Respimat. I've got adult patients who I will tell them to use a spacer. All right. Do patients with vocal cord issues, can they also have a history of asthma? Vocal cord dysfunction?
Yeah, absolutely they can. And I see plenty of patients that do. And so if patients have signs and symptoms of both, then go ahead and treat for both. So if they have signs of asthma, meaning they cough, they wheeze, they have chest tightness, the symptoms occur 10 to 15 minutes into exercise. At the same time, they're describing some instances where they have trouble with inspiration, with stridor, throat tightness a few minutes into exercise, then they absolutely can have both. And so, depending on the severity, you could start with that Combivent Respimat because it's got both albuterol as well as ipratropium. And so you could be potentially treating both. And sometimes you need exercise studies to tease that out. Sometimes you might treat for exercise-induced bronchoconstriction, whether that be with inhaled corticosteroids or something else. But absolutely you can.
Okay. Slightly off topic, kids with the EIB, if they are having to use albuterol several days a week, would you start them on an ICS or SMART therapy?
Got it. So yeah, this comes up a lot. So SMART therapy is same medication, it's Symbicort, which is budesonide formoterol. That's what the studies were done with, and Symbicort for maintenance and reliever therapy. So actually, SMART therapy is not something that I start patients on because it's really for step 3 and 4 on that algorithm. It's really for patients who are on an ICS plus a long-acting beta agonist, 2 puffs twice a day as maintenance, who are using albuterol as their rescue. If they're not well controlled, then you can step them up to SMART therapy, which means they're taking that ICS LABA 2 puffs twice a day, but then instead of using albuterol for their rescue, they're using the Symbicort for their rescue. So I really don't start with SMART therapy. I consider that more as a step-up regimen. And so when thinking about placing patients on a inhaled steroid, I think of 2 things. One is their impairment, and 2 is their risk. So impairment is a little bit different than frequency of symptoms. If they're coughing almost every day, but not needing rescue therapy, and they're sleeping and going to school and participating everything, I'm not going to be overly aggressive. But if, as you mentioned here, they're needing their bronchodilator several days a week, if they're not sleeping at night, if they're not able to go to school or go outside or fully participate, then absolutely I would be aggressive in starting a controller medication for them. If a patient has very infrequent symptoms, but when they do get symptomatic, they end up in the ER on prednisone or in the hospital, I'm going to treat them more aggressively with controller medications, as opposed to patients when they get illnesses just have more mild symptoms that are managed at home. Inhaled corticosteroids are first-line therapy for maintenance therapy. They can be used both on a daily basis as well as intermittently with symptoms, depending on the level of severity. And it would be considered first line over something like Montelukast or something along those lines.
Just for the audience, you might run into MART as opposed to SMART. They're the same thing. It depends on which side of the Atlantic there's a preference. So, or I should say ocean you're on. So some countries have or areas, continents have prefer MART over SMART. Let's see. A related question. So if a patient's got a diagnosis of asthma, and let's say they're on daily ICS or daily ICS LABA to control their asthma, can they still get EIB?
Yeah, absolutely. They can. And so if a patient is on maintenance therapy, then maybe it's not enough maintenance therapy. I would say that usually daily controller medication would be quite beneficial. So I think most patients would be fine. but you could still see it. And along those lines, there's some data to suggest that for patients who only have exercise-induced bronchoconstriction or are otherwise totally fine, using an ICS-LABA, budesonide formoterol, for instance, prior to exercise is non-inferior to using daily inhaled steroids. And it's better, more effective than using albuterol alone. So the takeaway there is that patients who are quite active and are having symptoms with EIB, you could start by giving them a Symbicort inhaler and using that prior to exercise instead of just albuterol, and potentially avoiding the need for daily inhaled steroids in patients. So it's a nice way, it's more of a minimalistic approach. You get less exposure to the inhaled steroids, probably better compliance, and oftentimes equivalent efficacy.
Another question. Did you say to use a spacer with Respimat inhaler? I don't think the recommendation is to routinely use a spacer with a Respimat delivery device. Is that fair to say? And then at what age could you start CombiVent?
Yeah, so the way the Respimats are is that they're intended to be used without a spacer, and you need to do a breath hold. That being said, I have some patients where I want to prescribe a Respimat. So there's CombiVent, tiotropium, which is a long-acting anticholinergic that can be used as add-on medication for asthma. Sometimes I want to use that medication for patients who can't do a breath hold. That also comes as a Respimat. And although there's no published data, in speaking with these companies, they have looked at this, and you're going to get some of the medication in when you use a Respimat with a spacer, but probably not as much as you would get in if you were to just use a breath hold. And so I find that the youngest really that I found that can use a Respimat without a spacer is like 6 or 7. And that's not all patients that age. But there's definitely times when I want to use it. I don't really see vocal cord dysfunction in that young of an age group, but there might be instances where you want CombiVent for other reasons. And so if they can't do a breath hold, I have no problems using that spacer with a face mask. Just know you won't get the full dose of the medication.
Any other questions? Let me just see. Let me just, are there any sports with an increased risk of EIB or asthma? You know, I think a lot of us have heard, you know, if you're a swimmer, the chlorine, generally most kids are swimming in chlorinated water.
Yeah, I definitely
any
see
sports?
that. I don't think there's one sport versus the other, big picture, but I definitely get a lot of patients, especially if they're indoor swimmers with air quality. If they're having problems, I find that anticholinergics, even outside of vocal cord dysfunction, anticholinergics as pre-treatment can be quite helpful in that air quality. So for those patients, oftentimes I will use CombiVent to pre-treat for sure.
Risks of systemic side effects with inhaled steroids.
Yeah. So
Yeah.
there are some things we know, and there are some things we don't know. So first and foremost, I would say that 99, if not 100% of the time, when you're thinking about using inhaled steroids, the benefits outweigh any potential risks in my mind. There are some that we know about, though. So for instance, there are local side effects such as rash on the face and thrush that you know about that are perfectly preventable by wiping the face with a washcloth, giving something to drink, brushing your teeth. There's an idiosyncratic side effect that I see sometimes with inhaled steroids, that being significant behavior change. It's very rare, but I prescribe the medicine enough to that we see it sometimes, and it's usually aggressive, out of control type of hard to control behavior. And I find that if it's with one inhaled steroid, it's to most of them, and it's not subtle. In those situations, I try to get cyclesonide approved by insurance. That's a newer inhaled steroid that is a prodrug, and it gets metabolized to the active form in the airways, so there's less systemic absorption. Insurance won't cover it though unless you show failure to other things, but that could be an option. I don't think we know much about long-term bone health with inhaled steroids, but we do have good data on height. And so what we found was that if you're using medium to high doses of inhaled steroids for long periods of time, and you're not decreasing the dose based on severity of disease or coming off for the summer months, you have a potential to, one, get a slowing of growth. You tend to get longer amount of growth. However, the data shows that you can potentially lose about half an inch of what you otherwise would have obtained. Now, for some people, half an inch isn't a big deal. For me, you can't see because I'm sitting down, but I'm just under 5'7". I'd love to be over 5'7". So I take it seriously. So I follow, for patients on medium or higher doses of inhaled steroids, I do follow their growth curves. And if I see a slowing of their growth, I'll either decrease the dose, add in a secondary steroid-sparing medication, something like that. But I really don't see growth issues with patients on low-dose inhaled steroids, especially since most patients can come off of the medications over the summer months.
Any other questions for Dr. Nelson? Can inflammation from not
Yeah, I see it.
yeah from I'm guessing it's from ICS increased vocal cord dysfunction?
As far as we know, there's inflammation doesn't play any role in exercise-induced vocal cord dysfunction that I'm aware
of. Can cigarette smoke exposure worsen vocal cord dysfunction or precipitate?
It's a good question. I don't know the answer to that. I'm not familiar with data looking at that. Obviously, cigarette smoke exposure is not good, and so I would counsel against it anyways. Whether or not it would induce vocal cord dysfunction or vocal cord issues, I'm not sure, but it obviously can lead to a whole host of respiratory issues. But I'm not familiar with anything really that other than significant reflux causing kind of like aspiration almost, leading to worsening of vocal cord issues.
What about in the pediatric population? I'm not a pediatrician, I'm adults, but what about dysphonia with ICS use in the pediatric population?
That's something that we see from time to time, much more common if you're not using a spacer than if you are, and oftentimes rinsing helps as well from that. So I see it, but it's pretty rare.
Okay. Any other questions? Oh, sorry. Inflammation from allergies. Any issues?
It can definitely lead to lower airway problems along the lines of asthma. But I have not seen, in the absence of anaphylaxis where you get angioedema and upper airway swelling and things like that, I haven't seen, seasonal allergies, something like that lead to vocal cord issues. But I could imagine if you have significant postnasal drip or sinus issues where you have a lot of stuff dripping down in the airways, it could potentially irritate the upper airway, but probably not, super common.
We're at 8 o'clock. If there are no further questions, wait. Why are steroids not given as much during the summer? You had mentioned that, just curious.
Yeah, so by far and away the number one trigger for asthma is viral illnesses. And just the mere fact that there are less viral illnesses circulating during the summer and patients spend more time outdoors, that oftentimes even patients with severe asthma, you can either decrease the dose of inhaled steroids required over the summer months or come off completely. I would say the vast majority of my patients, I try to take them off in the months of July and August, just to give them a little bit of a break, because oftentimes it's not needed in those summer months. But then you got to be careful heading back into school with a change in weather and being exposed to things. But a lot of people can come off of their inhaled steroids over the summer months.
All right, thanks again, everybody, for attending, and thank you, Dr. Nelson, for a great talk and Q&A. Again, please fill out the CME form and submit them once you close out of this webinar. And I look forward to seeing all of you again at a future talk, and I wish you a good rest of your day. Thanks again, Dr. Nelson. Take care.
Thanks for having me.